ఈ కెమెరా దీనికి ఉంది, దీనికి ఉంది, వస్తుంది, అది కూడా వస్తుంది. నిన్న మను ఏమో చేసాను. ఎట్లా చేంజ్ చేశారు మను, నాకు గుర్తురా. ఇదే పర్లేదు, బాగానే ఉంది కదా. యాక్చువల్ గుర్తురా. ఇదా రిమూవ్ ఫ్రమ్ స్ట్రీమ్. ఇదా ఇక్కడ చేశారా అండి మనం?
ఇదే వస్తుంది సెట్టింగ్స్ కదా.
ఇదే వచ్చేసి
కొంచెం అట్టు కలుపుకోండి. అవును కాదు.
కాల్ చేశారా? కాల్ చేశారా? ఇది సర్క్యులేట్ చేసేసారు అన్న గ్రూప్స్. ఒక 1 మెంబర్ అయినా జాయిన్ అయితే స్టార్ట్ చేయండి. మాట్లాడదాం. Uh, somebody has joined. Thank you so much for joining us today. So let's start with today's class. The last point we left was at 1:38. So I'll go to that point. Sorry guys, we couldn't take a continuous class for you because I wasn't in the city. Voice రావట్లేదు. Unmute ఉంది. Hello. వస్తుందా? So hopefully from today we'll be taking the regular classes. I'll try to finish maximum portion of yours. So we'll go a little more fast today. I've added few pictures. So let's start with today's class, okay? So, yeah. So yeah, management of IBD we've done with this. So yeah, I've added some pictures. I was saying that have a look about proctoscope. This is how a proctoscope looks like. Okay. This area, this is a handle which we'll be holding as a practitioner, and this area goes inside the anus. This area goes inside the anus. Okay. This is a proctoscope. If you keep going to the hospital wards, you'll definitely be seeing this, especially in the surgical OP. We're done with peritonitis also. We'll start from here. I was saying yesterday that mouth is the first site of digestion. We have three pairs of salivary glands. First pair is the parotids, which is near your ears, and then you have submaxillary or submandibular just below your mandible, and in the front you have sublingual, okay, which secretes saliva to the oral cavity. Approximately 1.5 liters of saliva is secreted daily. Parotid, submandibular, sublingual glands. These are in pairs. And mumps is a viral infection which affects the parotid glands. It's very commonly seen in children. Submaxillary or submandibular gland is a gland with the longest duct. So we were here last class. Intestinal obstruction. What is intestinal obstruction? The name itself says there's an obstruction in the intestine. It's the blockage or obstruction in the intestinal tract which prevents the normal flow of content via the intestine. There are two types of obstruction. One is a mechanical obstruction, second is a functional obstruction. Mechanical means that you have again examples in these are intraluminal obstruction due to pressure on the intestinal wall. Mechanically, there is an obstruction. Example, you have a tumor, you have adhesions, you might have a stricture. Stricture is normally this is how a tube looks, but if you have a stricture, this is how it might look. There's a kinking here that can lead to the intestinal obstruction. Stenosis is again narrowing of the lumen. Stenosis is again narrowing of the lumen. It could be because of carcinoma, anything, a tumor. Then intussusception. I'll show you pictures. Intussusception is the wall of the intestine goes inside. Show you. Then you have functional obstruction. Functional obstruction is the musculature cannot propel the content of the bowel. So there is improper peristalsis. The musculature of the intestinal wall isn't working properly. So that is what is leading to the functional obstruction of the intestine. We'll come to this point. I'll show you the pictures of intussusception, volvulus, how adhesions look. Okay. So 139 point. Again, coming back to the 30 high yield points for your nursing exam. I've already explained this to you. 4.8 or weight bearing gait is the most commonly used when both the legs are in the weakened condition. Where do the nurses stand? The nurses stand towards the affected area. This I told you. 3-point gait is or non-weight bearing gait is used when the injured legs can bear some weight. 3-point swing through is used to keep all pressure off from the injured legs and swing both the legs through. So, if this is the point of your clutch, your legs will be swinging through. Swinging through is putting your legs here. Swinging through is putting your legs a little ahead. You'll be swinging through. Gout is a syndrome of acute attacks of arthritis caused by hyperuricemia. High uric acid levels can lead to gout. Incidence of primary gout is more in men than in women. Limited intake of purine-rich food. Example, liver and sardines. Sardines are a type of fish. It is advised for people to avoid this, which is very high in purines, which lead to high uric acid because purine metabolism is what which is responsible for high uric acid levels. So to prevent that, we tell these people to not take these which are purine rich to avoid the precipitation of the acute attacks in gout patient. Waste products of digestion. The brown color of the fecal matter is due to breakdown of bile. So bile duct, pancreatic duct, both are entering right together at the ampulla of Vater. So if you have your duodenum, okay, this is your second part of duodenum. यहाँ पे you'll have your ampulla, this duct, bile duct, common bile duct and pancreatic duct, both open here, okay, into the ampulla of Vater. It has a valve, and all these secretions is excreted into the second part of the duodenum. Duodenum. This is duodenum. So, whatever bile that enters into the intestine is again broken down, and that is what causing the color of the fecal matter. Chemicals formed by intestinal bacteria such as indole, okay, are responsible for the fecal odor. So the odor is being caused by the indoles and the sketols, which are the chemicals formed by the bacteria. So bacteria are responsible for the odor, and bile is responsible for the color of the fecal matter. Internal anal sphincter. So you have anus. If you have anus, you have two sphincters, internal and external. I already told you, external sphincter and the superficial, the upper sphincter of the esophagus is both in our control. It's in the voluntary. We can control those both sphincters, but the remaining part of the GIT is not under our control. So internal anal sphincter is under autonomic nervous system control. So we don't have a control over it. External anal sphincter is under voluntary control. You can control. Of it is under control of somatic motor nerves. Okay. So internal is under autonomic control. External is under somatic nerve control, which exit the spinal cord at S2 and S4. So if you have any kind of disc prolapse which causes any kind of pressure over this nerve which is exiting from the S2, S4 level, it can lead to issues with defecation. What is stool test? Name itself, if you're testing the stool, it is you collect the stool specimen and you check for the consistency, the color, okay, for any kind of blood, for ova, oocyst, stool, inspiring stool specimen for consistency and color, firstly, and then stool for occult blood. Stool specimen are collected on random basis unless it's quantitative study. So random sample should be sent to the lab immediately. Take a random sample. There's no time specific thing here. Quantitative specimens should be refrigerated until they're taken for the laboratory. Stool for occult blood is a screening test to detect colon cancer in early stage. So if there is any kind of colon cancer, definitely these patients are passing blood in the stools. So you want to detect that. That's how we can catch early stages of colonic cancer. What do you do after that? You do a colonoscopy. You can also take a piece from that area for biopsy, and that's how biopsy is the confirmatory test. In stool, occult blood testing is done to detect heme. Blood में क्या रहता है? Heme, and that is all iron laden, iron containing pigment of the hemoglobin. This test is contraindicated in a patient with hemorrhoidal bleeding. So the cause of the bleeding here is hemorrhoid. It's not CA colon. And usually you put a proctoscope or you do an endoscope, sigmoidoscope to see where these hemorrhoids are. If the cause is hemorrhoids, then definitely you don't want to, puncture that area because it will lead to continuous bleeding. They're all like veins there. False positive test result can occur in occult blood test if the patient has eaten meat, liver, poultry, turnips, broccoli, cauliflower, sardines within 7 days before testing. So what here, all these are food which can cause a little bit of bleeding because of constipation in the stools. So this can give us a very false positive test. So tell the patient to have a normal diet, but control on all these things which can actually cause a false positive test. Medications such as aspirin, ibuprofen, indomethacin, corticosteroids, anticoagulants, cancer chemotherapeutic agents can cause false positive. Obviously, you know how aspirin, they're all blood thinners, so definitely this, on and off it can cause a little bit of bleeding in the stools. So this can also give us a false positive test for the occult blood when you look out for the occult blood in the stool. So what you do is you ask a proper history to the patient, whether the patient has eaten all these foods which can cause a false positive test, or if the patient is on these particular medications. What are the key points here? In a patient with ulcerative colitis, use of cathartics are contraindicated because it might lead to megacolon perforation and death. Cathartics once again. So, in patient with ulcerative colitis, use of cathartics are contraindicated because it might lead to megacolon perforation. And what does cathartics mean? Is it's something similar to laxatives. So you don't want to increase the amount of peristalsis in this patient. If you do that, it can precipitate to megacolon perforation and can also cause death, especially in ulcerative colitis. You have to be careful. Colostomy care is what? Output from the colostomy is known as effluent. Okay, whatever collects in that bag is called effluent. Skin barrier and the colostomy pouch should be of right size to fit the stoma well. Stoma is the opening over the skin. Small openings may obstruct and make the stoma swell. So if you have a very small opening and there's a lot of feces coming out of it, effluent coming out of it, if there is a small opening, it's unable to come out. It can lead to obstruction. What happens? All that area can get infected. The stomach can swell. Large opening will cause leakage. So you need a correct size and correct bag to prevent leakage or to prevent swelling of the stomach. Try to perform colostomy irrigation at that time when the patient usually had bowel movement before colostomy surgery. So before the surgery, if that patient has had a bowel movement, then you try to irrigate that area. This is all just to prevent infections which the effluent can cause or the fecal matter can cause. Colostomy irrigation works well if performed after a hot drink. So ask the patient to take hot drink and then you can do this irrigation. Colostomy irrigation is preferably performed at the same time every day. Okay. Avoid food items producing gas such as eggs, broccoli, cabbage, onions, fish, beans, all the milk in its products like cheese, butter, carbonated drinks, alcohol, all these are all gas producing agents. So you want to avoid them. Food items causing odor to be avoided. You have most of the garlic, onions, cheese, cucumber, eggs, cabbage, fish, dairy products, coffee. So try to have a very sattvic food, especially when you have this colostomy bag. What's a chancre? Reddened, circumscribed lesions. I have pictures for you. I'll show you. Reddened, circumscribed lesions that ulcerate and become crusty. They first of all they form like an ulcer, red ulcer, and they get crustated. These are called chancres. It is a primary lesion of the syphilis and is contagious. Soak, especially cold soak. This happens mostly in the lips areas, anywhere in the body. In the men, it can happen on the penis. So, what do you do if it is on the mouth or the lips? You do a cold soak, with, then you give an antibiotic, okay, and that is about chancre. Then you have something called leukoplakia. Leukoplakia is white patch in the buccal mucosa. Leuco means white. Okay. Erythro means red. So leukoplakia is a white patch in the buccal mucosa, which is usually painless. You instruct the patient to consult doctor if it is persisting for more than 2 weeks because all these things are precancerous lesions. So if these are coming into the patient's mouth, you have to tell the patient to go and have a look with the doctor or undergo a biopsy, because definitely this can lead into oropharyngeal carcinomas. You have to catch, these are all signs. Okay. Then you have something called hairy leukoplakia. These are white patches with hair-like projection. There's no real hair there. It has hair-like projections like this. So if this is your tongue, okay, we are seeing the lateral part of the tongue. Okay, यहाँ पे ऐसे ऐसे करके you have this white hairy projections. Okay, over the sides of your tongue, the lateral aspects of your tongue. That is called hairy leukoplakia. It is white again, but it's like hair-like. So white patches with hair-like projections, most balsac commonly occur. Okay, with, avoid that point. It's a hair-like structure which commonly occur on the lateral borders of the gentian violet. So whenever you're trying to stain the tongue, you can see that all that areas around gentian violet, when you're doing it with the gentian violet spelling, is wrong here. So this is the chancre which I was been talking about. This is on the lips. So you can see this red ulcerated lesion which can get crusted. Okay. This is leukoplakia. So oral examination is being done. You can see this, all this white patch below the tongue is your leukoplakia. Okay. It's a precancerous condition. This is I think I missed the point where we had hairy leukoplakia. ठीक है, कोई नहीं. This is lichen planus. This is lichen planus. I'll tell you what lichen planus is first. So we were talking about hairy leukoplakia. It is seen especially in HIV patients and patients who are taking tobacco constantly. So what is the treatment here is valsiclovir. You put the patient on valsiclovir and then you can do a gentian violet staining for this. Oral lichen planus are white papules which are painful. So leukoplakia is usually painless, but this lichen planus is painful, usually ulcerated. It may develop as a malignancy. So it's like proper fibrosis of the buccal mucosa here. Can you see here all these white lesions here like this? Okay, all this area, all this is all lichen planus, and usually you have a tight feeling, difficulty swallowing, difficulty chewing, and these are usually painful, and they can predispose to cancer. So what is the treatment here? You're giving a corticosteroid and you're avoiding the substance which is causing irritation. So the patient is taking a lot of gutka, tobacco. You tell the patient to avoid it. Next, layers of digestive system. Just a second. Oh, hi doctor. Thank you so much, Dr. Ashu. Layers of digestive system. Uh, we talk about it from in to out. So first layer which is inside is the mucosa, followed by submucosa, and then you have the muscularis layer, and then at the last you have serosa. In the esophagus, remember that serosa is absent. You have no serosal layer in the esophagus. But in other parts of the intestine, you have all these layers: mucosa, submucosa, muscularis, and serosa, or it's also called as adventitia. Mucosa is the innermost layer, contains many of the goblet cells which secrete mucus. So, if normally in your intestine you have ciliated columnar cells, right? In between this, you can see this goblet cells. I said. So these are your goblet cells. This pouch-like thing which secrete mucus. These are your goblet cells. So if usually in the exams, if you're given a H&E of intestine, and you can see cilia, you can see long, tall cells along with goblet cells, just you can blindly answer it as at a smaller, long intestine accordingly. So these are the goblet cells which you can see in between these cells. which are the main function is to secrete mucus. Mucosal layer also contains villi in some of the parts to increase the area of absorption. Usually, villi you see it in small intestines, villus, something like this, finger-like projections. Okay, these are called villi. This is to increase the area of absorption. Then you have submucosa, just below the mucosa, which contains nerves. So I told you that Meissner's are submucosal plexus, meandric are in between the muscles. So this is Meissner, which is submucosal, and you have something called meandric, which is muscle layer. It's present all along the intestine. Then you have blood vessels in the submucosa. You also have elastic fibers with collagen. Muscularis layer consists of both longitudinal and circular. So it has both longitudinal and circular layers, which help in continuing the peristalsis. Muscles का एक ही काम है to push the food towards uh, towards one unidirectional. So the muscle is mainly involved for peristalsis. And serosa in that muscle layer, in between those two layers of circular and longitudinal cells, you have your meandric plexus, which I was talking about in the previous slide. And then, lastly, the outermost layer is serosa or adventitia. It is made up of loose connective tissue, which is coated in mucus so as to prevent any frictional damage from the intestine rubbing against. All the intestine is all nearby, na? ऐसे करके small intestine, and then you have the large intestine here. Huh? तो सब बाजू बाजू है, तो you don't want any kind of a frictional damage when two intestines keep rubbing amongst each other. So to avoid that, you need to have some kind of a substance in between both to avoid friction. That's the mucus. So all coated with mucus to avoid frictional damage. Then you have lower GI tract study or barium enema. So if you're giving the barium from below, that's called enema. Above say there you're checking for small intestines, stomach and all that area, it's called barium swallow. Barium enema is you're giving it from down. It's in the name, enema. All you nurses know what enema is. Okay? When barium is instilled via rectum to visualize GI tract, it is known as barium enema. In double contrast or air contrast enema, air will be instilled following barium. So in double contrast, first you're pushing air followed by barium. That's called double contrast or air contrast enema. In this study, air will be filled in the lumen, which is lined with the barium and allows easy detection of small lesions. So if you have your intestine like this and you're pushing air first, air will all occupy this lumen, and the corner of that lining of the intestine is all coated with barium. So any kind of small lesions you can easily catch. The purpose of barium enema is to detect polyps, tumors, other lesions in GI tract. Any kind of discontinuity in the lumen can be detected. Any filling defect can be seen. Bowel preparation is necessary before procedure. Obviously, before you go for an enema, all that area has to be cleaned. Access before we give barium, you have to definitely ask the patient if the patient is allergic to barium, or you do a small test to see if the patient is allergic to it. Also, you ask about varied other allergies like iodine, shellfish, or seafood before the procedure. But if the patient is allergic to all this, you cannot perform this test. Then after, if you're doing a double contrast enema, so what are you doing in double contrast? You're pushing air first and then followed by barium. Especially in double contrast, the patient can experience a bit of cramping and discomfort. Then you have something called low residue diet, which you follow 2 days prior to this procedure. You need the bubbles to be emptied more quickly and has to be clean. Okay. So we follow low residue. Low residue, naam mein hi hai. You don't want it to sit inside the bubbles. It has to get cleared out. Clear fluid diet is preferable a day before, and laxatives in the evening before the procedure. So if you're posting for the procedure at 8 a.m. in the morning, so if you're posting for a procedure at 8 a.m. in the morning, what are you going to do? You're going to tell the patient that तुम है ना lunch के time से from the lunch time try to maintain liquid diet, preferably the whole day. Also, in the evening, just before he goes to sleep, tell the patient to take laxatives. You give them Dalcolax tablets so that they have easy defecation in the morning before they reach the hospital for the procedure. Other than that, from 12 a.m. in the night till the procedure, you tell the patient to be nil by mouth, nothing from mouth, no water, no food, nothing from mouth. Okay. Cleansing enema once the patient reaches the hospital, because that area is what which we are concentrating on. We'll do a cleansing enema in the morning on the day of the procedure. If upper GI study is also there, it has to be done following lower GI. So you do first lower GI and then upper GI. Okay. Barium enema study is contraindicated in patient with perforation. Definitely, if you're going to give that in a perforated case or in an obstructive of this in kind of active bleeding, it is contraindicated. Fluids are encouraged after the study to eliminate contrast. Obviously, now whatever that contrast has got accumulated has to be pushed out. It has to be either come via your feces or via your excretion, urination. So you tell the patient to take more amounts of fluids for us to prevent any kind of toxic damage because of barium. Stool color will be changed to chalky white because the barium comes out on the stools also, and that gives a chalky white color while barium sulfate is getting eliminated. If a patient is taking tablet metformin, it has to be avoided a day before because it can mix up with barium and it can lead to lactic acidosis with the contrast agent. So you're avoiding metformin. What is the reason? Lactic acidosis is the reason. You avoid metformin before this procedure. Again, coming back to the high points, Paget's disease is a disorder of bone remodeling process. Okay, and then we have scoliosis. Scoliosis, I already told you, is a lateral curvature of the spine. Skyphosis is the outward curvature. Skyphosis is what you see in old patients in 90 years, 85 years. पूरा ऐसा bend हो जाता है ना, तो that is skyphosis. It's also called as humpback. Lordosis is inward curvature of the lumbar spine, especially in pregnant women. The terms you can see lumbar lordosis in those patients, which is mostly the cause of discomfort for the pregnant women. Patients with prolapsed intervertebral disc are advised to sleep on one side with hip and knee. You have a pillow in between two legs, and hip and knee usually like you sit in like a baby position. Okay? But if you're trying to extend the legs, now those are actually painful. Okay. C5, C6, C6, C7 are the most common sites in the cervical area for a vertebral prolapse. And in the lumbar, I've already told you it is L3, L4, L5, S1. Yeah. L4, L5, sorry, L4, L5, L5, S1 are the most common sites for the lumbar vertebral collapse. So in the cervical, it is C5, C6, C6, C7. In the lumbar, L4, L5, L5, S1. Prone position may be recommended. Prone is you're sleeping over your tummy following an amputation of the lower limb. You try to keep cushions in between. Also give them support below their legs. Okay. In lower limb amputations, tongue should not be elevated on a pillow. So you're not trying if he has had a lower limb amputation, you don't want to put the limb in a little flexed position because that can lead to contracture and that's not comfortable again. So try to keep it as flat as possible. It is to because it can lead to flexion contraction. That's why we avoid elevate the limb, especially if they've underwent a lower limb amputation. If physician recommended, then the foot end of the bed can be elevated, not the limb, but the foot end can be elevated. Why are you elevating foot end? It's just to reduce the edema. But if you don't do anything to the bed and you try to keep a pillow below that stump, it can lead to flexion contraction. In above knee amputation, prevent the external rotation of the stump. So you try to keep sandbags at the corners of at the lateral aspect of your thigh. In below knee amputation, discourage prolonged sitting and hanging the stump while sitting because obviously gravity can lead to edema in that area or that stasis of that edematous fluid can lead into infection of the stump area. Amputation that includes all levels of thigh amputations from hip to the knee joint is known as transfemoral. So from hip to the knee joint in the thigh region is known as transfemoral amputations. Intrahepatic bilirubin circulation. Bilirubin is released from the breakdown of RBCs at the reticuloendothelial system. What is the reticular? Your spleen. Okay, that is one of the areas where these RBCs are broken down to release bilirubin. Hepatocytes also, once this reaches the liver, they convert this bilirubin, which is unconjugated form, to conjugated bilirubin. So whenever this bilirubin initially is produced as unconjugated form, once it reaches the liver, it is converted to conjugated. And this by mixing it with what? Glucuronic acid, which is more soluble in aqueous solution. So all this conjugated bilirubin is what? Which is actually secreted into your urine, which turns into urobilinogen, which is finally giving the color to the fecal matter and also color to the urine. Later, this conjugated bilirubin in the hepatocytes will be secreted along with the bile into the duodenum. You know it is getting secreted into the second part of duodenum through the ampulla matter along with the pancreatic duct. In small intestine, the bilirubin is converted as urobilinogen. That is what imparting the color. A part of urobilinogen is excreted via feces, and another part is reabsorbed again into the system, and that is finally being excreted out into the urine. It reaches the liver, so whatever the blood is being reabsorbed goes into the portal venous system, again reaches the liver via portal vein, and the remaining part enters the systemic circulation, finally being excreted through kidneys in the urine. So I'll repeat this again, it's very important. Bilirubin is released from the breakdown of RBCs in the spleen, okay, reticuloendothelial system. Remember this. Once it is broken down, this bilirubin is being released through this uh, through, from the spleen, from the reticuloendothelial system. It's entering into the liver, and the hepatocytes will convert this unconjugated. This is all in unconjugated form, which is not very soluble. So this is getting converted to conjugated form in the hepatocytes in the liver through glucuronic acid, and this conjugated form is more soluble. Later, this conjugated bilirubin is being secreted into the second part of the duodenum, and in the intestine, a part of it is going into the feces, and the remaining part is being reabsorbed into the portal system. Once this portal system reaches the liver, again वहाँ पे it enters from the portal system to the systemic circulation, and then finally it is being excreted through the kidneys into the urine. This is enterohepatic biliary circulation, which is very important for us and for you all. Next, disorders of esophagus. What is dysphagia? Dysphagia is difficulty in swallowing. Okay, if you have any kind of discomfort in this area when trying to swallow, it is called dysphagia. Odino is painful swallowing, especially in achalasia, or if you have any kind of aphthous ulcers or any kind of infection in this area where you're trying to swallow, it can lead to odynophagia. Next, you have dyspepsia. What is dyspepsia? Indigestion is what is commonly the term indigestion is nothing but dyspepsia in our textbooks. It involves discomfort or pain in the upper abdomen. Jal raha hai, jalan, all the inoads are all being spoken for dyspepsia and Giuliani. Okay. Then you have functional dyspepsia. What is functional dyspepsia? It's because of H. pylori infection. How do you treat it? With antibiotics. So your H. pylori is what which is mostly responsible for GERD, for peptic ulcer disease, for dyspepsia. So to avoid this, you put those patients on antibiotics. You can put them on proton pump inhibitors. You can give them drugs which reduce the acid secretion. Okay, all these things can help with dyspepsia. Also, avoiding spicy, oily, smoked foods can also reduce dyspepsia. And telling the patient to not sleep immediately after a meal, asking them to sit for a while or have an active workout. Workout in the sense like moving about in the kitchen or in the room, whatever, little bit of workout. That is what which is important. If you take it very Indian way, usually in Indian system or yoga follows that if you sit in Vajrasana, post your food, it helps in digestion and it can actually help in dyspepsia. Next, what is achalasia? Ineffective peristalsis in the distal area, the last area of the esophagus, and failure of the esophageal sphincter to relax. Two things are happening here. The esophageal sphincter is not relaxing, it is not allowing the food to enter into the stomach, firstly. Secondly, you have ineffective peristalsis in that last one third of the esophagus. It's called echalacia cardia. Okay, what do you do here? Treatment is calcium channel blockers. Uh, Other than that, you'll tell the patient to eat frequent meals but small quantities, not eating very bulky meals at a time. Suppose you have missed your breakfast and you're having your brunch. Eat brunch like very little only. But if you eat it like lunch with a combination of breakfast, it is not going to sit well with this echolation patients. So small frequent meals like for every 2 hours, a little bit, or taking soft diet, semi-liquid diet can help these patients with echolation. Mouth, we've already spoken about it. Salivary glands are in the mouth which secrete saliva, which contain talin or salivary amylase. So you have a little bit of digestion going on into your mouth also. So it's very important for the food which is into your mouth. You don't immediately swallow it. Tell you na, that you have to chew. Acha chaba ke khana. Huh? So when you actually try to chew the food into your mouth, all the saliva gets mixed up and little bit of digestion occurs into your mouth, which is very important. So the salivary amylase or stannin, tyalin, however you pronounce it, is what is secreted by the salivary glands. So starch, especially carbohydrates, are digested at the mouth. 30% of starch is hydrolyzed by the action of the salivary amylase. Starch plus salivary amylase, this combination will give rise to maltose. Pharynx and esophagus. Okay, यहाँ पे क्या होता है? Pharynx, esophagus, stomach. Pharynx, esophagus is especially helpful for in peristalsis and swallowing. Okay, so helps in swallowing and carrying food from mouth to stomach. थोड़ा सा डाइजेशन मुंह में हो रहा है, फाइनली द नेक्स्ट डाइजेशन अकर्स इन द स्टमक, बाकी जगहों में नहीं हो रहा है. तो यहाँ पे एवरीथिंग इज गेटिंग मिक्स्ड अप विद द सलाइवा एंड फाइनली दैट हैज टू रीच द स्टमक बिकॉज द एसिड इज वेटिंग फॉर द फूड. सो HCl, intrinsic factor, pepsinogen, pepsin, all these are being secreted into the stomach, which helps in the further digestion of the food. Intrinsic factor combines with the vitamin B12 and helps in its absorption. This absorption doesn't occur at stomach, it occurs at the ileum. Okay, यहाँ पे it is getting mixed up. Intrinsic factor and HCl, I've already told you. HCl along with intrinsic factor, both are being produced by parietal cells. ये parietal cells कहाँ पे होते हैं? They are in the stomach. Intrinsic factor here will combine with B12, but this absorption takes place in the ileum. But you need intrinsic factor for the absorption of the vitamin B12. It's like trapping. You're trapping the vitamin B12. If you have intrinsic factor deficiency, which occurs in pernicious anemia, B12 is not getting trapped. It is what jo bhi B12 you're taking is finally coming out into the feces. So what happens? You have B12 deficiency leading to megaloblastic or the pernicious anemia, is what which we call. So this trapping ke liye you need the intrinsic factor. The mass of the food that is semi-digested, it is acidic, it is pulpy, stomach में, उसको बोलते हैं shine. Yesterday I told you, last class में मैंने बताया था, तो इसको shine कहते हैं. Okay? Shine is what that is semi-solid food which is mixed with acid, and HCl converts inactive form of pepsinogen to pepsin that is required for digestion of the proteins. Pepsin converts proteins into peptones and proteases. Then you have prorenin, which is a proenzyme, which is converted into renin by HCl. Then you have casein, which is seen in milk. It's a milk protein. It's converted into peptides by renin. So renin is important for converting casein into peptides. Yes, sir, all this thing is happening in the stomach. And finally, from stomach, when it is getting pushed out to the pylorus into the duodenum, that food or that semi-pulpy acidic food is called chyme. Small intestine, now the food has entered into small intestine. Small intestine, like what is being produced? Bile juice is coming, okay, that has some kind of digestive enzymes. Along with that, you have even pancreatic juice, which also has digestive enzymes. So you have trypsinogen, you have chymotrypsinogen, you have elastase, you have carboxypeptidase, all at ACE. ACE means enzymes. Okay, pancreatic lipase and amylase. All these things are being secreted into the small intestine where the chyme is waiting, okay, for these juices to act on. Then you have bile and bile salts, which is being produced from the common bile duct. So enterokinase is what which converts trypsinogen into trypsin. Trypsinogen is in an active form; it is getting converted to trypsin, and trypsin converts protein into dipeptides. Trypsin converts chymotrypsinogen into chymotrypsin. So what is enterokinase doing firstly? It is converting trypsinogen into trypsin. One. Then this trypsin is converting proteins into dipeptides. And trypsin also converts chymotrypsinogen into chymotrypsin. And this chymotrypsin converts the peptones into dipeptides. Finally, sub dipeptides where protein digestion is getting 30% of starches in the mouth. But most of the major protein digestion occurs into your stomach and your intestines. Then you have fats, fatty acid and glycerol with the help of pancreatic lipase. नाम में ही है, lipase मतलब lipids. So it is cleaving the lipids. And bile salts. Both of this are required for the digestion of the fats. So fatty acids and glycerol. With the help, the fats are converted to fatty acids, free fatty acids and glycerol with the help of pancreatic lipase and bile salts. Carbs. So already 30% of thing is got digested into the mouth. Maltose ho chuka hai, what is waiting. So more of these carbs are again converted into simple sugars or monosaccharides with the help of pancreatic amylase, not lipase, amylase. So pancreatic lipase is for fats, pancreatic amylase is for carbohydrates. And all the remaining trypsin, chymotrypsin, all those are again required for the proteins. Fats and carbs are having very simple this thing, but when it comes to your proteins, you have a lot of enzymes being used up here. Okay. What is hiatus hernia? Hiatal hernia. Hiatus means a gap. Okay. Esophagus. Uh, this is your diaphragm, and यहाँ पे you have your esophageal opening. Normally, your lower esophageal sphincter is placed here, and finally, यहाँ से stomach निकलता है. Okay. Please excuse my horrible diagrams. This is your pylorus. Huh? यहाँ पे stomach है. This is esophagus. This is the lower esophageal sphincter. This part gets herniated into the thoracic cavity. There are types in it. Firstly, one of the types is sliding type. Okay. Second thing is rolling type. For nurses, I will not go into depth of what it is, but I'll show you pictures just for easy understanding. Just remember that hiatus hernia has something to do with the herniation of a GI tract, especially the esophagus or a part of the stomach. Normally, what all this stomach is all into the abdomen, but what happens is a part of it can enter into the thoracic cavity. That is what is through this opening of this esophagus in that opening of the diaphragm. So that is what is called hiatus hernia. These are all internal hernias. Esophagus enters into the stomach through an opening in the diaphragm known as hiatus. In hiatal hernia, this opening becomes larger and upper portion of the stomach moves into the lower thorax. Two types. Type 1 is sliding, upper portion of the stomach and the gastroesophageal junction. Okay, यहाँ पे I'll show you the picture. Upper portion of the stomach and the lower esophageal junction or that gastroesophageal junction. You have an LES, that's a lower esophageal sphincter. वहाँ पे all these are displaced and then moving into the thoracic cavity. Type 2 is paraesophageal. Just beside the esophageal, you have a weakening of the diaphragmatic wall. So वहाँ से a part of the stomach will move into the esophagus. Sliding type is not a true hiatus hernia. Paraesophageal type 2 is what is called true hiatus hernia. So in very symptomatic form, this is your stomach. Okay, this is your thoracic cavity. And this is your abdominal cavity. Stomach is normally supposed to be there in your abdomen. यहाँ पे you have your gastroesophageal junction. All this thing ना will slide. यहाँ पे slide हो रहा है ना ऊपर की तरफ into the thoracic cavity. This area, this hole in the diaphragm through which the esophagus enters into the abdominal cavity, finally opening into the stomach. It's called hiatus. Hiatus. तो यहाँ पे slide हो रहा है ऊपर. Hence it is called sliding hiatus. यहाँ पे क्या हो रहा है? This esophagus, LES, the sphincter is all in its normal place. A part of the stomach, cardiac, the head of the stomach is actually sliding into the. It's going into the thoracic cavity beside the paraesophageal, beside the esophagus. Because it is beside the esophagus, it's also called as paraesophageal. ठीक है? So this is the true form. ये ट्रू वाला है, ये फॉल्स वाला है. Both are hiatal hernias only, but the proper true hernia in this hiatus hernia is the rolling or the paraesophageal. This is also called as rolling. ये sliding. Okay. Next, what can happen here whenever you have this kind of hiatal hernia? एक तो heartburn can occur, regurgitation because you're disturbing that lower esophageal sphincter part. No? So all that GERD can occur here. Dysphagia is where you have difficulty in swallowing, so this all this acidic problem. Reflux is most commonly seen in sliding because it is sliding more upwards into the thoracic cavity. So the control of the muscle is kind of lost in the sliding type. So especially reflux is seen in the sliding type. But in paraesophageal, because a part of that stomach is going, there's only very little amount of stomach left for the digestion. You kind of feel fullness. Feeling of fullness is more felt in the paraesophageal or the rolling type. But you have reflux more commonly in the sliding type. How do you assess? You'll do an X-ray, you can do a barium study, you can do a fluoroscopy to see where these parts are. Management is for sliding hernia, elevation of the head end of the bed during or after feed. So what is the main problem in sliding hernia? You have a reflux. Reflux में क्या करते हो? You elevate your head and sleep, ना? Or you don't sleep immediately after eating. You have to sit straight for some time. So all these things you do in this sliding hernia. Usually, surgery is needed for permanent correction. Otherwise, you don't really touch it. Paraesophageal में क्या है? You have to do an emergency surgery because that portion of the stomach which has entered into the thoracic cavity can undergo torsion. Once it undergoes torsion, क्या होगा? Severe pain. Okay, the patient might go into shock. Secondly, all the blood supply to that area can get compromised, and that part of the tissue can undergo necrosis. Gangrene can occur. So all this can lead into toxic shock. So you want to avoid it, you do an emergency. Any kind of strangulated hernia, you know it's an emergency. So paraesophageal में 100% सर्जरी करना जरूरी है. स्लाइडिंग में स्लाइड कर सकते हो, मतलब you can wait for some time. You can try to avoid this reflux. So you do a surgery for permanent correction. It's not an emergency slide. Normally hernias, if you feel as a doctor that if it is it's going to undergo any kind of a strangulation, or if it's a irreducible hernia, then in such cases you recommend surgery because you don't want the patient to end up into a strangulation. Hernia is a condition in which a part of the organ is it's displaced. It's not in its normal position and it protrudes through the wall of the cavity. Wherever you have a weakened wall of the cavity, वहाँ से it goes. There's an outpouching. उसमें जाके this abdominal contents, because of raised abdominal pressure, it goes and gets herniated into that pouch. Surgical repair of hernia is known as herniorrhaphy. Herniorrhaphy में क्या करते हो? If you have to repair, you push all those intestines or the part of the abdomen which has herniated back into its place, and then you place a mesh. Esophageal diverticulum. Diverticulum, it's in the name. It's an outpouching of the mucosa and the submucosal layer through the weak muscularis portion. So the muscle layer, I already told you esophagus lacks serosa. So in diverticulum you can commonly see, and especially the muscle layer. So I told you that you have mucosa, then you have submucosa, and then you have muscularis. So if this portion becomes weak, these two layers can undergo an outpouching. Okay. One of the examples for this is Zenker's diverticulum. So in your esophagus, you have different muscles. Okay, there is one particular space. I'll show you in the pictures. Zenker's is also called as paraesophageal diverticulum. It's most commonly seen in the upper portion of the esophagus. यहाँ पे you have two muscles of cricothyroid, yeah. यहाँ पे you can see two different kind of muscles. एक तो you have longitudinal muscles and then you have circular muscles. Okay, cricopharyngeus. Cricopharyngeus has two type of muscles. Just remember that one. So इसमें what can happen? That cricopharyngeus के दो muscles के बीच में, if that muscle, usually it's a weak area. So वहाँ पे this mucosa and that submucosa can undergo an outpouching. Side say if you see, this is how this outpouching will look like. Okay, and in this little bit of food, whichever you eat, can go get accumulated in this, and this is not getting ejected out through your normal GI peristalsis, finally entering up into a fecal matter. यहाँ पे जम के it is becoming a dirty substance. It is getting stagnated there. And whenever this patient tries to talk to you, you'll have very bad breath coming out of the patient's mouth because of this stored food here, okay, in that diverticulum. And that symptom or the sign is called halitosis. This patient will have bad breath. This is one of the examples of esophageal diverticulum. So most commonly seen in the upper portion of the esophagus, and then you have epiphrenic. Phrenic nothing but is nothing but diaphragm. Epiphrenic diverticulum is the largest diverticulum, which is seen in the lower portion. Whereas the diaphragm is just at the lower portion of the esophagus, right? So the lower portion of the esophagus, just above the diaphragm, can also undergo a diverticulum, which is called again epiphrenic, which is the largest diverticulum. Clinical manifestation is in paraesophageal diverticulum. What can happen is paraesophageal. So I just told you nothing but if this is your esophagus, just beside it, if you have a diverticulum, this is called paraesophageal. You have difficulty in swallowing, you have fullness, just like that hernia which we have learned about. Then you have regurgitation of the undigested food. Because all this, यहाँ पे, there is hardly any space in the stomach. So it can undergo kind of a regurgitation. That food kind of gets accumulated. That is what is called paraesophageal. This is the clinical manifestations of the paraesophageal diverticulum. All these are seen in the esophagus. Halitosis, bad breath, sour taste in the mouth are common because of the decomposition of the food which is retained in the diverticulum. And in such people, endoscopy is contraindicated. You don't do endoscopy at all because if you try to do endoscopy, already that area is weakened. You can end up causing a perforation. So you don't do an endoscopy. In endoscopic finding, you can actually see like a band-like structure. यहाँ पे if this is how we see on endoscopy. Normally, you will not do. ऐसे दिखता है. You can see it like this on an endoscopy. This is the endoscopic finding. You can see a band-like structure. जहाँ से you can see you have an extra एक ही cavity होना चाहिए ना, एक ही lumen होना चाहिए. But you can see two here. That's what is Zenker's diverticulum. It is contraindicated. You're not supposed to do it. So halitosis and sore taste in the mouth. How do you assess? You do a barium study. You take X-rays. Esophageal manometry is to rule out motion disorders. Then you do esophagoscopy. Sorry, it's contraindicated because risk of perforation. We're not doing an endoscopy. Management is you have to remove the diverticulum. So you do an ectomy. Diverticulectomy is a surgery of choice. Very simple. What is echolalia? Echolalia, I already told you, lower esophageal sphincter is not relaxing and you have difficult peristalsis in that lower part of the esophagus. Stomach is a distensible pouch located left to the midline, just under the left diaphragm. Capacity is 1500 ml for stomach. Okay, the inlet of the esophagus into the stomach is known as esophageogastric junction. It's in the name, Esophagus is entering into the stomach. So esophagogastric junction. Esophagogastric junction is surrounded by a ring of smooth muscle, which is known as LES, lower esophageal sphincter, or the cardiac sphincter. Cardiac doesn't mean heart. It's called cardiac because that area of the stomach is called cardiac. So don't think it is something to do with the heart. So stomach is divided into four regions. Entrance is called as cardia, and then you have the fundus, and then you have the body, and finally you have the pylorus, which is the outlet. So inlet is the gastroesophageal junction, which is the lower esophageal sphincter, entering into the cardia, then goes into the fundus, then into the body, and then into the pylorus, which is the outlet. Circular muscle in the wall of the pylorus becomes the pyloric sphincter. This is esophageal achalasia. यहाँ पे क्या हो रहा है? You don't have proper peristalsis in this area. ठीक है? And this lower esophageal sphincter is supposed to relax for allowing the food to enter into the cardia of the stomach. But this is not relaxing. It remains constricted. And when this remains constricted, that lower portion of the esophagus can undergo dilatation. This is what is called achalasia. This is normal. यहाँ पे normal lumen you have. This is the lower esophageal sphincter, which relaxes whenever there is peristalsis. But यहाँ पे it is not relaxing. You can see it's all near. It's completely closing of the lumen. And what is happening because of the pressure? यहाँ पे आके food जमा हो रहा है. So that undergoes dilatation. That area of the esophagus undergoes dilatation. This is how it looks on in barium studies. You can see this bird beak appearance. Does it look like a beak of the bird? Okay. This is the head of the bird. This is the body of the bird. So, यहाँ पे this area is supposed to enter into the stomach, but because of this not non-relaxing of the lower esophageal sphincter, this has become the dye is not able to pass completely, and यहाँ पे the lower part of the esophagus has dilated. Pyloric sphincter is what? The outlet of the stomach. It controls the opening between stomach and small intestine. Stomach produces 2.4 liters of gastric juice per day. Saliva कितना है? 1.5. Gastric juice is 2.4 per day. Gastric chief cells, or it is also called as peptic cells or zymogenic cells, secrete pepsinogen, okay, which helps in digestion of the protein. Parietal cells, it's also called as oxytonic cells or delomorphous. Sometimes in the exam, they may not use as common terms as parietal cells and chief cells, which we are aware about. They might use other names. So remember that chief cells are also called as zymogenic cells or peptic cells, which secrete the pepsinogen, which helps in digestion of the protein. Parietal cells are oxytonic cells or delomorphic cells, which secrete HCl and intrinsic factor. Intrinsic factor is essential for the absorption of vitamin B12 in the ear, not in the stomach. Gastroesophageal reflux disease, GERD, we've already learned about it, so I'll go a little fast. Backflow of the gastric or the duodenal content into the esophagus because of the relaxation of the improper functioning of the lower esophageal sphincter. Incompetent lower esophageal sphincter, or it's also called as cardiac sphincter. Pyloric stenosis, or due to motility disorder. So even if you have an outlet obstruction, this can lead into finally precipitate into reflux. Why? Because there's a lot of pressure. That pressure has to go somewhere, na? So it will go up. Excuse me. Okay. So incompetent lower esophageal sphincter or the cardiac sphincter, and then you have pyloric stenosis, which can also predispose as GERD. Clinical manifestation is the patient will complain of pyrosis, which is also heartburn, uh, just behind your sternal area, And you have dyspepsia, same, that burning sensation. Dysphagia because of the acid, difficulty in swallowing. Pain can occur because of the erosion, so the corrosion which has occurred because of the acid. Odynophagia, these people can have a lot of aphthous ulcers. And esophagitis, because all that esophagus where that acid is being refluxed leads to irritation of the esophagus, leading into inflammation of the esophagus. Assessment is endoscopy, or you can also do a barium swallow to evaluate damage, kitna damage हुआ है मुझको समझो. And you also do scintigraphy to assess gastric emptying. How is the food or the diet getting empty? Okay, and then you do ambulatory esophageal pH monitoring to evaluate degree of acid reflux. Keep moving the patient and in various positions to keep checking the pH. So in layman terms, this is the esophagus, this is the cardio of the stomach, here you have fundus, this is all the body and this is the pylorus. So here you have your LES, lower esophageal sphincter. Normally the acid is supposed to stay here in the stomach, but if you have a pyloric stenosis or if you have an incompetent lower esophageal sphincter, all this can get refluxed into your esophagus, going up. Okay, this is what is called esophageal reflux disease. For this, we do hydrogen breath test, or there's one more test called urea breath test. This is to detect the H. pylori. This hydrogen wave, what happens is this test determines the amount of hydrogen expelled in the breath after it has been produced in the colon and absorbed into the blood. This test is to evaluate carbohydrate absorption, and this test is also helpful to evaluate bacterial overgrowth. Just remember that the hydrogen and the urea breath test both is to evaluate the bacterial overgrowth. If it is being produced too much, then you know that there is a lot of bacterial overgrowth into the GI system, which is finally leading into the GERD. And urea especially is to detect H. pylori infection. Patient is given a capsule of carbon labeled urea and then the breath sample is taken after 10 to 20 minutes. H. pylori metabolizes urea rapidly and the labeled carbon gets absorbed quickly. It can be determined by measuring the carbon dioxide into the expired air. Patient is instructed to avoid antibiotics and loperamide. Motility drugs and antibiotics you ask them to avoid taking it at least for 1 month prior this test. And then sucralfate and omeprazole are the treatment for H. pylori peptic ulcers. Other than that, you can also give it for GERD. This is one, you tell this patient to avoid all this. अगर ये test करना है to avoid everything which reduces the bacterial load, which treats the particular cause, because it can give us a false negative test. Okay, sucralfate and omeprazole, you also tell the patient to avoid it a week prior to this test. Cimetidine, ranitidine, famotidine, nizatidine, also you tell the patient to avoid it. These are the drugs which decrease secretion of acid 24 hours before the test. What do you do for GERD? एक तो खाने के बाद एकदम सोना नहीं है, not allowed to sleep immediately after food. Do a little bit of cleaning the table, putting the dishes. Some work, at least for half an hour. And you sit at least for 1.5 hours. Okay, don't go and sleep immediately. And even if you have to sleep, try to elevate the head end of the bed. इसके अलावा you also try to do lifestyle changes, because one of the major causes of GERD is lifestyle modifications. So you tell the patient to stop smoking, wear loose clothing. Weight management is very important because GERD is very common in obese patients. And you take smaller, frequent meals and sleep with head elevated, shoulders elevated, and avoid any kind of trigger foods like spicy, smoked foods, okay, oily foods. All these should be avoided. So today we are actually done with 1 hour of class. Tomorrow hopefully we take a 2 hour session. We're sorry we didn't inform you about the class today, but tomorrow in the morning we'll inform it in the group. क्या time को रहेगा? Okay. Thank you so much for joining me, doctor. That's my. Thank you, Ashu. I don't know if it's a guy or a girl. Thank you so much for joining me on my lecture. Okay, guys, today we'll end here. 158 is the point, and we'll start 158 from tomorrow. Hopefully, we have a 2 hour session tomorrow. Thank you so much. Have a nice day. Suresh, बंद చేసేసారు చేయనా